Hello, and welcome to the Level 3 study group on 9:30 for eye movement assessments. I'm your instructor, Dr. Kathy Dooley. I am one of the Level 3 instructors for the Australia team, and also I assist David here in New York City, and I'm proud to do it. Eye movement can be a confusing thing to assess, so I want to make sure to help you in any way I can, help to optimize the movements, and also talk to you a little bit about how it can affect perturbation. I also want to talk to you about why you would go to eye movement, which may be a partial thing that you want to be able to investigate and see if you should be focusing on it. Anybody that has a subsystem issue is likely to have an eye movement issue associated with said subsystem. It doesn't necessarily mean that the eye movement is the propagator of the dysfunction. So a couple of things just first about eye movement. Eye movement is innervated by both midbrain and by pons. So we have all of these extraocular muscles. We have 7 major ones and 6 that actually move the eye. The rectus muscles are on either side of the eye in like a cross, like a cruciate form. So the superior rectus is above your pupil. The inferior rectus is below your pupil. The medial rectus, of course, is at the equator, at the inner canthus, and the lateral rectus is at the outside of the eye. So it's very important to remember that these 3 muscles are where their location is, and the fact that 3 out of the 4 of them have a shared innervation. Superior rectus, inferior rectus, medial rectus are all innervated by cranial nerve 3 and are midbrain innervated. On the lateral aspect of your eye, this is lateral rectus. Lateral rectus is innervated by cranial nerve 6, which is at caudal pons, so a completely different area. And you know the expression, things that wire together, fire together? Well, lateral rectus completely opposes the medial rectus on the same eye and completely opposes the opposite side lateral rectus. So it's important to remember that some of these things share innervation or are likely to share dysfunctions within the same system, and some things are antagonistic. And we know about antagonisms in NKT, they tend towards dysfunctional relationships. Now, some of your other muscles that we have of the eye are the oblique muscles. The oblique muscles actually start very medially and end up on the lateral sclera, kind of flanking the lateral rectus attachment. So the superior oblique belly starts at the upper medial aspect of the eye. So if I were to point that out to you here, it's right there. And on the inferior oblique is the only muscle of the eye that starts from your maxilla. All the rest of these muscles came from your sphenoid bone. So the inferior oblique actually starts at the maxilla and then heads out laterally. Now, David shows you in your level 3 Vimeos, as does Thomas, that a great place to therapy localize is at the scleral attachments down on either side of the lateral rectus. If lateral rectus is at the outer canthus, then the superior oblique is going to attach superior to that, inferior oblique is going to attach inferior to that. These are fantastic places to therapy localize and for you to understand where to put your Q-tip and check for tenderness also and tightness. Now, I also want to encourage you to palpate the bellies. The bellies can have a rich amount of proprioception, and there's a lot of carryover between the superior oblique and inferior oblique proprioceptive attachments on the lateral sclera. So if you're not getting very clear testing and it's kind of not very logical with your exam, you want to make sure you also palpate here and here. So inferior oblique at the maxilla going this way, and superior oblique using a trochlea or a pulley to go around and underneath superior rectus to come over to the lateral sclera above the lateral rectus. Now, superior oblique has a completely different innervation than all the rest of the things we discussed. Superior oblique is trochlear nerve, which is caudal midbrain, so a little bit of a different area. And inferior oblique shares that cranial nerve 3 innervation. So it's the same innervation as superior rectus, inferior rectus, and medial rectus. So we have 3 nerves that are brainstem innervated, and we know that things that are associated with midbrain and pons have an enormous effect on motor control. If you've not already been studying this at depth, the pons and the cerebellum come from the same embryonic center called metencephalon. And we know the cerebellum is what we keenly test during manual muscle testing. So if something's missing motor control, it goes to something that's embryonically related to it. People go to their jaw because that's pons innervated. And people go to their eye movement because it's pons and midbrain innervated. So if you're coming from the same area, you'll want to compensate with those things. Now, these patients, though, will usually complain of eye problems, and you may have to ask them about it. These people have eye strain. They tend to have a prescription that's uneven. They tend to complain of possibly a droopy eyelid, which is associated with cranial nerve 3. They may say, oh, I get diplopia, I get a little bit of double vision. They may have trouble doing certain things, and I'm going to help you key into what those difficult things are. And when you start to match these with the different subsystems that you learned in level 2, it can elucidate a ton of information, help people with their eye pain, help them with their habit change, and possibly get them out of weird stuff like headaches, neck pain, and particularly help them get out of subsystem issues. It's always weird when you can get like a lateral rectus release to actually let go of a global pattern of SI joint pain associated with the subsystem. Really cool stuff. So investigate into the history and ask some questions. Are they a glasses wearer? Are they a contacts wearer? Have they had a history of eye strain? Do their eyes get really heavy when they look at a computer or read or do a certain activity? Find out what activity that is. Watch them do, if you can, set activity or get in that position and start to do some eye testing. Now, we know what these muscles do, right? We know that they are triplanar. So we know that the superior rectus muscles tend to elevate the eye, inferior rectus muscle tends to depress the eye. And then we know the obliques are opposite. The inferior oblique elevates, superior oblique depresses. I always remember the O's go together. Obliques are opposite of what you think they'll do on the x-axis. Medial and lateral rectus work on the y-plane. So medial rectus adducts, lateral rectus abducts. So you can see that they are going to have a major effect on frontal plane movement. So if you have a lateral subsystem problem, holy moly, definitely look at eye movement if part of their history is that they have eye issues. The obliques also have a triplanar movement like most of these muscles do, as do the rectus muscles. The superior rectus and inferior rectus adduct the eye. They pull the eye towards the midline. So they don't just elevate or depress respectively, but they can also adduct, so they can pull you inwards. They're not as good at it as medial rectus, but they can do it. The obliques also abduct. And I always remember obliques abduct. So the OB and the AB go together. Thank goodness. It's like a gift from the anatomy gods. So your rule is this. If you don't understand the movement, it's very hard to understand the clinical testing, which is actually what we use during our NKT testing. But what they do is not go short on each axis. What they do is go short on one axis at a time, and that produces our results. This is called link tension curve in physics. So if you're short on one axis, you're then suddenly not available to be powerful on another axis. And let me give you an example. For someone who has trochlear nerve palsy affecting the superior oblique, that person will have trouble looking down when the eyes are in. So they'll have double vision when they walk downstairs, when they read the paper. Now I just told you that the obliques abduct. Why do they have trouble when the eye is in then? When they have trouble when the eye is out? The answer is no. If the eye is in adduction, that means the superior oblique is pulled into a stretch position. And we all know what happens when something goes on stretch. It's ready to fire on a different axis. But if it's short on an axis, it's not going to be available. Like if I take this rubber band and I kind of squish it, it's not powerful anymore. So superior oblique is the most powerful depressor of the eye to read your paper, to walk down the stairs when your eye is in adduction, because that means the inferior rectus is busy doing adduction. And if the inferior rectus is busy doing adduction, it's not going to be a powerful depressor of the eye. So the patient will complain of superior oblique problems. They'll say, I get double vision or eye strain when I'm reading down, when I'm going downstairs, because the eye is adducted, superior oblique is knocked out, and nothing's able to depress the eye. So clinical testing and anatomic relationships are different. And it can be very confusing for the student. Believe me, this is why I created a separate YouTube video for this that's on the bottom of your notes. I highly suggest you watch Dr. Kento Kamiyama and myself go through these eye movements so you can understand the difference between movement and the difference between link tension curve. For the rest of this study group, I'm going to assume you already know these things, okay? And if you don't, you can pause the video at this time, go watch that video, study up, and come back. This is eye testing. So I'm gonna walk it closer. So basically what happens is this. If we're gonna be doing eye testing, we're gonna be watching what's called the cardinal signs of gaze. So we're gonna go up and down as we go laterally. We're gonna abduct the eyes. We're gonna go over to the other side, and then of course, elevate and depress. And what this is gonna do is it's gonna teach us which dysfunctional patterns may be very, very difficult for the patient to execute. So when you're doing a basic cardinal signs of gaze assessment, you kind of have to know what you're looking at. For instance, if I were to have the patient start to go directly to this right side, their eyes are looking to the right in the frontal plane. Do you guys see how the lateral rectus on the right side is going short and the medial rectus on the left side is going short on that axis? That's easy. That's like the easiest one. The same would be true for the opposite side. If you were to bring into accommodation, then you have a bunch of adductors being able to help you, but you're mostly testing medial rectus and its ability to function in adduction on each side. Now, as I have the eyes in adduction, like the center point of the patient, as I move upwards, I'm in adduction of the eyes, which means I'm testing the inferior obliques. So the inferior obliques are tested when that relative eye is in adduction and elevation. As I come downwards, if the eye is adducted, we're testing the superior obliques, because again, the superior oblique depresses the eye when the eye is in adduction. That's because it's not busy doing abduction. It's stretch loaded on the y-axis to help you depress the eye. Now, if I were to have the patient look over to the right, I'm using lateral and medial rectus, right? Right lateral rectus, left medial rectus. As I move from this fully abducted right side and adducted left side position, as I move upwards, do you see how now the right eye is in abduction and elevation, which means the inferior oblique is not available to be able to pull the eye up. So the only muscle you're now testing in this right side abduction and elevation is the superior rectus. That's because the superior rectus is now stretch loaded on the y-axis, so you're only testing superior rectus. On your left eye, the opposite's true, right? So if I go both eyes to the right, I'm adducted on the left eye. As I go into elevation, now I've knocked out any of the other elevators of the eye that also help me to adduct. So on the left eye, I'm testing the inferior oblique. So you have to remember length tension curve when you're doing the eye testing. Now in Australia, my group found this to be way too complicated, so I made up a little dance. If little dances help you, then you're gonna be good to go, okay? So if you imagine me being an H for this, the cardinal signs of gaze, right? Where this is adducted and this is abducted, and this is our frontal plane, yes? Then if I had you here, this is lateral rectus at the equator. Here, medial rectus, okay? Lateral rectus, medial rectus. If you're up here, superior rectus. Down here, inferior rectus. If I come in and I'm down, superior oblique, inferior oblique. And on a rough day, that might get you through it, right? Superior rectus, inferior oblique. Medial rectus, lateral rectus. Inferior rectus, superior oblique. So if you need a goofy dance to help you out, knock yourself out. You can use that, okay? Or you can just draw it out and put it in your office and think it out for yourself until you get really, really solid on it, okay? So just remembering that functional movement is a little bit different than studying what these do on each axis, just to ease your confusion. So remember, medial rectus here, obliques are going to be on the inside here because they're the most powerful elevators and depressors when your eye is in adduction. If your eye is already in abduction, now you're stretching you're shortening the obliques and stretching the rectus muscles. So superior rectus will primarily elevate you when your eye is abducted, and inferior rectus will primarily depress you when the eye is abducted. I promise you, if I can learn this, you can learn this. It's not that bad, okay? Now, we didn't talk about intorsion and extorsion. Now, David leaves that out of level 3, and I understand why. It's a coupled action between elevation and adduction, but the eye has true triplanar movement, like the shoulder, like the hip, only it doesn't have the limitations of the shoulder and hip, actually. It has a little bit more freedom. So intorsion, extorsion is movement away from and towards the nose. So if I'm going towards my nose, this is intorsion, and extorsion is movement away. And so this can greatly affect transverse plane movement, right? So we want to also consider the fact that we might have intorsion, extorsion affecting your ability to be able to move freely on the transverse plane. With most eye movement, I'll think, oh, if I'm up at a quadrant up here or down here, a good thing to check would be anterior and posterior oblique slings. So you see us perturb things today if somebody has problems in one of those lateral extremes, right? If it's a more medial extreme, I find a little bit more intrinsics because those are more towards the center, and also, of course, sagittal plane movement in elevation and depression. Now, we all know that people are on their phones all the time, and most people are not on their phones like this, disciplined to look down, they're like this. So there's a big link between eye movement and head position. The suboccipitals and SCM actually are very keyed up to eye movement. So a great place to look for tonicity in people that have eye strain, if you really want to be testing this stuff, is hypertonicity through SCM and hypertonicity through the suboccipitals. Now, on your perturbation testing, if eye movement has the biggest effect, head testing probably will give you the clearest response. So instead of just testing at the shoulder or at the hip for perturbation, you might get the best total response from eye movement at the head because it's so linked to something called the vestibular ocular reflex. Your position of the head is related to your eye movement. So just, no absolutes, like David says, but just consider the fact that the perturbation fail that you might get might be a little bit better up here. So now that we've understood basic cardinal signs of gaze, we can actually pair what we see in those cardinal signs of gaze to different problems and subsystems. Of course, medial and lateral rectus are going to be the key ones for the lateral subsystems, right? Elevation and depression are definitely going to be key to frontal plane problems like A to P perturbation. And then if we have these extreme problems with one corner and a different corner, transverse plane would be a good place to look for that intorsion, extorsion relationships between the structures. If you need to know who intorts, who pulls you in, anything called superior oblique and superior rectus. The things that extort you, that pull you out, are called inferior. So inferior oblique, inferior rectus. You can also do a really, really fun test to determine if the problem is on one eye or possibly between two eyes. And this test is a super easy test. It's a basic triangle test. So what you do is put a triangle with the patient, say, hey patient, can you do this? And can you find like a letter on my shirt that's central, right? So you have them center up on something where their head is not changed, their neck is long, chin is tucked, and you're not making any compensations with the neck. And you have them hold a triangle and have something in the center of that triangle. For me right now, it's the light on my computer. And after you find center, you're gonna have them close one eye and see if the area shifts, see if that central structure shifts. And then you'll close the other eye and they'll basically tell you if it shifts successively. What we would expect on eyes that have codominance is that there would be a shift as you close one eye. But in people that have one eye dominance, what will happen is when you close the weaker eye, that structure will stay central. This is a person where you stay on the eye that moved, right? So if they have one eye that fixates, that's a very dominant eye, and the other area, it goes into a big deviation from the triangle, then that person has trouble on that eye between those parts of one eye. Now, if they do the triangle test and there's a big deviation on one eye and then a big deviation on the other eye, that's eye-to-eye problems. So you'll check one eye to another eye. Of course, there's no absolutes. If that doesn't work, definitely consider staying on one eye. These are just suggestions based upon tendencies, right? If you have a dominant eye that can fixate and then another eye that can't, the odds are that the person will have symptoms on the eye that can't get neutral. And so you would look for relationships within that one eye, right? But if the light or the central structure that you have in the triangle deviates, whether you close one eye or the other, then you want to look between eyes, okay? And the cardinal signs of gaze test tells you which area to look for. So rather than just talk about this, let's actually do it, okay? So we've collected some people that are able and free during this lunch hour to be able to help us delineate some eye problems and where we would start. So we're going to do a cardinal signs of gaze assessment. We're also going to do the triangle test, some quick tests and assessments that we can do to understand where we would go with perturbation. We're also going to ask them some history of which subsystem has been the most problematic for them, and maybe that would help us. We're not going to be limited towards that because we're going to do our own perturbation and see what happens. Okay, so can I borrow you? Can you sit in the corner here for me? And can you tell me if everything that we're doing stays in the camera lens? If it doesn't, just let me know, because I'm about to go behind the camera and I won't be able to tell. So Sky, you're first up, right? The amazing Sky. Sky Roberts, you're a level 1 instructor.
Yes.
Oh my gosh, we're so lucky to have her here assisting us in NKT. And do you get any eye strains?
I do.
Okay. Do you have one eye that bothers you more than the others?
My right eye bothers me more than the other, and I kind of get floaters, but I don't have high blood pressure.
Okay. So one eye definitely working really hard to try to do stuff. Okay. That's super good information. And do you know if you have a subsystem problem?
I think I have a lot of subsystems.
So that's no help at all.
Right.
That's okay. What we're going to do is we're going to do our 2 basic tests for eye movement. Okay. So I'm going to do a cardinal signs of gaze test first. I'm going to do it, and then I'm going to do it behind the camera. First, behind the camera, I can't see much. So I'm first going to do it for Sky here. So Sky, can you face me here?
Mm-hmm.
Okay. So I'm going to stand at least 2 to 3 feet from the patient, and I'm going to have a central point for them to focus on. I don't want them to move the neck at all, and I want them to be able to focus on the spot. So Sky, I want you to focus on the spot for me. And we're going to move first just in the lateral plane to the left. So her left eye should be abducting, and her right eye should be adducting. Her right eye is having a very hard time being able to adduct. And then let's come up. This is testing the left superior rectus and the right inferior oblique. And Sky is having an epically hard time on this right eye doing that. She's trying to move her head to do it. She's so clever. If they start to move the head, have them stop and try to reset them. Sky has less trouble down here. I'll start to look for their eyes to water a little bit, and I'll ask them, do you need a break? Just to blink a couple times?
I was starting to get a little bit of double vision on that.
Oh, this way down. Okay, so let's look at that again.
Well, no, just in general.
Oh, in general.
Up
Okay, so
and
it could have been
down.
any of them. Okay, gotcha. Did you notice it started on any certain plane, Sky?
I think it started from the get.
I think so too. Start to see your eye water a little bit. Sky is a little bit better at this one. She moves the left and right eye equally into movement to the right, which is the right lateral rectus and the left medial rectus. And then Sky, as we move up here, she actually moves pretty freely. Little bit of trouble as we're coming down, but not much. And now we'll do accommodation, which is bilateral adduction, which is cranial artery mediated. I'm going to bring you closer, see if she can adduct. She is having an epically hard time adducting the right eye. It's starting to water quite a bit, so I'm going to give you a break. I'm sorry.
Yeah, right.
So now we're going to do that for the camera, and I'm going to step away and behind the camera so you guys can see what I saw. Do you need a break? Are you all right?
I'm good.
Kind of intense. Okay.
Okay.
All right. So you're going to face the camera as close as you can, okay? And I want you to look here, though. So I'm going to come right above the camera lens so they can get as close of an exam as we can remake on video. Keep your neck long and your chin tucked for me. There you go. Excellent. And Sky, you're going to follow this Q-tip. Just so you guys know on the camera, I'm holding the Q-tip. So we're holding the Q-tip right behind the camera lens. And we're going to move her to the left. We can see that her left eye goes into adduction, but her right eye, or abduction, but her right eye is having a hard time adducting. And she starts to water. She also tries to move her head. Can you centralize your head for me? There you go. Nice job. So let's try again. Just move the eyes. Eye movement and neck movement, head movement are very, very much linked. And now we're going to go up. We're going to go superiorly. The left superior rectus and the right inferior oblique. She's having a really hard time moving that eye up. And those are the most dysfunctional ones. Now Sky had a lot less trouble coming down, which is testing the left inferior rectus and the right superior oblique. We're going to come back to center, Sky. How you doing? You okay?
I'm good.
Need a break? You all right?
I'm good.
I let them have breaks as long as they need. So I don't want any false positives or negatives. You can see her eye very quickly goes into right lateral movement and left medial movement. So right lateral rectus, left medial rectus. Going down, a minor bit of trouble on the left, but not anything to write home about. We'll come back up to the equator, and now we'll come up a little bit higher. She doesn't love it, but she can do it. So the most dysfunctional thing that we see on you, Sky, is your ability to move the eyes to the left on the frontal plane, and then being able to move into elevation using the superior rectus on this side and being able to use the inferior oblique on this side. Now, to be able to determine if I'm going to stay on one eye or look at both eyes, we're going to do the triangle test. Okay. So what you're going to do is she's going to make a point with my hand. She's going to make a point with her hands. She's going to find a centralized spot. So I'm going to give her the Q-tip again. Okay. So Sky, can you find the center of this Q-tip with both eyes? Okay. Can you close your right eye and tell me where this shifted?
To the left.
Okay, so the left eye shifted it to the left. Okay, fantastic. And can you close your left eye?
Shifted to the right.
Okay, fantastic. So she experiences not a ton of eye dominance, and we have eyes in different relationships with each other. Okay, that is super duper helpful for us. Now we know we're not staying on one eye, we're including both eyes. All right, so now it's time for us to actually match what we saw and have her do some perturbation. So we have a feeling that Sky has a problem being able to move directly to the left and being able to move up and to the left. So it's either medial and lateral rectus in a paired relationship, or possibly even superior rectus on the left and inferior oblique on the right in a paired relationship. We might even have pairs between those structures, but she's definitely having trouble doing that as a family.
And I did take one of my 9 concussions was a blow that came up this way.
Oh, okay. So that way. So I want to test this lateral subsystem too. Okay, fantastic. So just, I got to remember now. I forgot. I apologize. That was a lot of information. Can you do the triangle again? Okay. And when you closed the left eye, it moved to the left. Was that correct?
When I closed the left eye, it moved to the left.
Okay, it moved to the left. And then when you close the right eye?
Actually, now it's staying to the left.
Oh, I may be in a little bit of different. How about that distance? So try to mimic the same distance each time.
So left eye moves to the left, right eye now is moving to the right.
Okay, that's what it was before. Fantastic. I was just making sure. So left eye moves to the left. So basically when you close the right eye and it moves to the left, that means you have powerful ability to be able to use your left lateral rectus. So I think, she's dysfunctional in being able to move her eyes to the left, but her lateral rectus has no trouble being able to abduct when the right eye is closed. So I'm thinking, she either has down-regulated medial rectus on the left eye or up-regulated lateral rectus on the left eye. The opposite is true on her right eye, right? Her right eye is having her eyes going over to the right. So this means that her lateral rectus on this side is very good at its job and the medial rectus is not. So she has these muscles that are both powerful on each of your eyes. You're very good at lateral rectus, not so good at medial rectus. Now we have to see which one of those might be the most dysfunctional. Since her injury was more lateral flexion based, we're probably going to be more interested in that as far as the sling issue, because these would be posterior and anterior sling, but nonetheless, we can start to include those as well. Now, Sky, did you see any kind of deviation going upwards or downward? Not so much on the triangle. Everything was just left or right shift. Okay, good. So lateral subsystem is definitely going to supersede the oblique slings, but it's a good place to start. But let's actually see if she's weak in the clear first. If she's not weak in the clear on the lateral subsystem test, then we can go into the anterior sling. Okay, for fun, we might do it anyway. Okay, all right. So let's stand you up. And probably this one you should face me. Okay. And we're still on camera. We're still good? Okay, great. And so, Sky. All right, let's flip over here, Sky, so that you get the camera. There we go. Perfect. So, Sky, you had trouble looking over to the left of the equator and looking up. So, for me, this looks like lateral subsystem here or anterior sling or posterior sling based upon the movement here. All right. So, what I'm going to do is push you from lateral to medial. First, I'm going to do it at the shoulder like we always do in level 2, but I'm really interested in the head part because you had a concussion. And so I'm going to be really gentle. I'm going to have my arm on the other side here to catch you. Okay? Take a deep breath in, all the way out, and then Dolomite push. So she has trouble rooting into her left foot. So this is left side AV and adductors and right side QL. Okay? So it's weak in the clear. So in order to see if your eye movement has a big effect on this subsystem, what I'm going to have you do is something that's a little bit more challenging for you and something that will actually be easier for you, okay? So let's have you not move your head, but move your eyes over to the left side, okay? You all right? Okay. Take a deep breath in, all the way out, and then do a wing push. She gives me a little bit of a better lock, even though we saw that to be dysfunctional and hard for you, right? Can you look up and to the left? Take a deep breath in, all the way out, and don't let me push. Also makes her very, very strong. So we have a little bit of work to do in determining which ones are the most dysfunctional. Probably tenacity and tightness. When we start to palpate with the Q-tip, it's going to tell us. Okay? Can I check your anterior sling and posterior sling? I'm probably going to stick with this lateral because it's a higher priority subsystem for frontal plane stability. Deep breath in, all the way out, and don't let me push. She's very strong in the clear. Let's see if looking to the left inhibits it. Support there. Deep breath in, all the way out, don't let me push. Oh, it does affect it, but it's strong in the clear. So probably not our easiest way into the cerebellum. Okay? And then posterior sling, one hand behind the shoulder, one hand in front of the hip. Deep breath in, all the way out, don't let me push. Then look over to the left. Deep breath in, all the way out, don't let me push. Okay, so a lot of the slings are turned off by the eye movement, right? Okay, we got a neural lock, which is dysfunctional. When you looked over to the left, it gave us a lock. Not so good, right? From your triangle test, we have to look eye between eye. Okay, now I'm going to recheck and see which one gave me the best neural lock. Was it straight to the left or was it up and to the left? Because they both felt kind of strong. So let's take a look. So look to the left for me. Take a deep breath in, all the way out, and don't let me push. Good. And look up and to the left. Deep breath in, all the way out, don't let me push. And now neither one are giving me a clear on which one's stronger. So what I'm going to have you do is I'm going to test at the head. Okay. I know you've had a concussion, so I'm going to be very gentle. Okay. I'm going to catch you. All right. Take a deep breath in, all the way out, and don't let me push. Good. And now still looking to the left. Yes. No. No.
I
Okay.
will look to the left.
Okay. Sorry. Well, look straight ahead. My apologies.
All right.
Deep breath in, all the way out. Don't let me push. Okay. She's holding her breath. Let's try that again. I know this is a threat to you because of your injury. So just deep breath in, and as you exhale, don't let me push. Okay. So she falls apart on that one. And then can you look directly to the left? Let me do that again. Deep breath in, all the way out. Don't let me push. Okay, that's a lot stronger. And now can you look up and to the left? Take a deep breath in, all the way out, and then don't let me push. That one's not as strong as it. There's a little bit of fudginess. So it looks like we're going to be checking this purely frontal plane, which kind of makes sense because it's a lateral subsystem issue. Okay. Can I recheck that anterior sling that really could not resist? When you're looking up and to the left, for this one, I just want to feel again, just to make sure. Take a deep breath in, all the way out, and don't let me push. Yeah, I just want to make sure that really, really failed. Okay, so if the lateral movement does not fix it, then the secondary correction that I would go after is the anterior and posterior sling relationships associated with her eye movement. Now, as far as your chief complaints, as far as a global compensatory thing, you've had all these head injuries, you have this eye strain, you have the floaters in the right eye.
I got tension.
Okay, I was just going to ask.
Tension.
Okay, so SCMs and suboccipitals definitely.
And I want to crack my neck all day and it never moves.
So basically, she was using head movement as a compensation for the eye movement that she was missing. So I do think those things might be linked, but I do think they're part of probably a global compensatory pattern with your eye movement. We're going to start at lateral subsystem, and then we'll move on into anterior posterior sling if they don't clear up. Okay, so if we're going into some tightness though for you, chief complaint areas involving the lateral subsystem. Do you have any? Do you have any adductor, abductor?
Adductor and abductor and both QLs.
Okay, so yes would be the answer. And as far as anterior sling, do you have any anterior shoulder, external abdominal oblique, internal abdominal oblique adductor?
This shoulder, a little bit.
Okay, so a little bit of anterior. Anything on the posterior I should know about, like
My lats are checked out.
Okay. Okay, very good. So we're going to prioritize like we would. She does have like a lot of problems within the lateral subsystem from right to left, and that's the perturbation that she fails. She gets a neural lock when she looks over to the left, even though we saw that to be very dysfunctional. So I think that we need to clear up this eye dysfunction. So let's use our level 3 skills to hack that. First, I might just test part of these subsystem things and see if looking actually gives me a neural lock, which would be interesting. Listen, hi, can you help me for a second? I'm going to bring you to work. Can you help me bring this table over to center? Okay. And now can you lay flat on your back with your feet down this way? So I'm going to test, or that too, either way, I'll accommodate you. So we're going to test her right QL and her left AB and abductors. We'll just see what they are in the clear. Take a deep breath in, all the way out, and don't let me pull. Okay, so right QL is weak in the clear. We'll check the tenacity and tightness to make sure it's tight. She did say that she had tightness there, and she does. Okay. You said hip AB and abductors both. Okay. So let's just do a general abduction test. I'm a better door than a window. Go. Take a deep breath in, all the way out for abduction. Don't let me push. Even with a breath hold, couldn't really get that done. And let's hold this here. I'm going to push her into adduction. Deep breath in, all the way out. Don't let me push. Also. Okay, so let's see and make sure that they neural lock when she does that dysfunctional movement of eyes to the left. So Sky, take your eyes to the left. Good. And just as in standing perturbation, this should give us a neural lock. Deep breath in, all the way out, don't let me push, and it does. And Sky will just wait a few seconds and we'll retest abduction. Okay, eyes to the left, deep breath in, all the way out, and then don't let me push. Okay, great. We'll give it a few seconds and we'll do adduction. Look to the left, deep breath in, all the way out, and then don't let me push. And it does. Just making sure. Okay, so now we get out our Q-tip and get out a fresh one. Okay, I'm gonna get a fresh Q-tip, and what I'm gonna do is try to investigate between those lateral and medial rectus muscles which ones may be the most tender for her. Now remember, when she did the triangle test, there was deviation to each relative side, which means she uses abductors well and not adductors well. And it's the same pattern for her on each eye, which is super interesting. It isn't always. So the first thought process you have to have is, what is she good at? Because what she's good at is probably going to be compensatory. So she's very, very good at left abduction and right abduction. But when she looks to the left, that actually uses left lateral rectus and right medial rectus. So the most probable compensator and tender thing for her would be either left lateral rectus or her right medial rectus, right? So look. And Sky, I'm on the lateral canthus of your eye. Do you have any tension there?
Not really.
Okay. And can you use your finger just to investigate that entire canthus area? Any tension?
A little bit right there.
A little bit there. Okay. And so now we're going to check the inner canthus for medial rectus. We suspect that this muscle might be downregulated because she has a really hard time being able to adduct. Any tension there? Okay. She doesn't have as much tension on this side. Now, because the triangle moved on both of her eyes, we have to assess both eyes. Now, Sky has a hard time looking over to the left, but when she actually closes and looks at the triangle, her right eye goes to the right. So her left lateral rectus might not be letting her medial rectus on this right side be able to move. Okay, so let's go ahead and see. Medial rectus here. Okay, she gets blinky and there's some tension there. Then how about the lateral rectus on this side?
Not so much.
Not so much. Okay. So she has a lot of medial rectus tension on this right eye, and she has a lot of lateral rectus tension on the left side. So let's think about that. What two structures move the eye to the left on each of her eyes? That is her left lateral rectus and her right medial rectus. She has this problem with her right eye. She feels a lot of fatigue. She gets floaters. And so it's highly suspect that her right medial rectus could be downregulated and that her left lateral rectus is a little bit too good at its job. Hopefully that makes pretty good sense, okay? Because those are areas of the highest tone for her too, the tightness is dysfunction. So there's a very, very good possibility that those are our two muscles that we're going to pair. But, you know, we're going to think about that, but let's first find an indicator, okay? So, Sky, what I can do is I can use your leg and not your arm. We'll actually see if we can use your arm. Let's see if it has tonicity to it. So tonicity is pretty low in her anterior deltoid. If you're finding too much carryover into the upper extremity with eye movement, you're welcome to use Recfen or something else down here. But she's pretty low tone in her anterior deltoids. I'm thinking it may not be in a dysfunctional pattern currently. So I'm going to go ahead and just muscle test in the clear to make sure it's strong in the clear. Take a deep breath in, all the way out, and then don't let me push. Okay, so that's strong in the clear. And now I'm going to spin a cell compression to make sure this muscle can be inhibited. 1, 2, 3, 4, 5. Deep breath in, all the way out, and then don't let me push, and it can be. So now when we qualify the indicator, what we're going to have to do is make sure that these aren't in a current dysfunctional relationship with the anterior deltoid. So Sky, with your left hand, can you actually push into your lateral rectus on the left of the outer canthus? Okay, she's just TLing to make sure they're not in a dysfunctional relationship. Take a deep breath in, all the way out, and then don't let me push, and she's fine. So now she's going to stimulate that in TL, which should throw some cerebellar dysfunction towards the area and make this go weak if it is indeed dysfunctional. Take a deep breath in, stim in TL, all the way out, and don't let me push. And it does go weak. So the left lateral rectus is dysfunctional. Now, can we do the same thing on the medial rectus? Can you TL? She's going to TL to make sure she's not in a dysfunctional relationship with the anterior deltoid. Deep breath in, all the way out, and then don't let me push. She's good to go. So now she's gonna stim in TL. Good. And then we'll retest. Deep breath in, all the way out, and don't let me push. Remembering that the stim in TL is bringing that cerebellar awareness to ask, is this dysfunctional? And yes, it is. So her lateral rectus on the left and her medial rectus on the right are both dysfunctional. Now we have to establish if they're a pair. So Sky, what you're gonna do is stimulate both and then TL1 with your left hand. Deep breath in, all the way out, and don't let me push. Good. So they cancel each other out, which means they are a dysfunctional pair. So now that we've done paired TL, now we need to see the nature of the relationship with DOD. So we're gonna do direction of dysfunction. She's gonna stimulate her left lateral rectus, and then she's gonna TL her right medial rectus. Deep breath in, all the way out, and don't let me push. Okay. And that goes weak, which means medial rectus is inhibited by lateral rectus, which makes complete total sense with her eye exam. But let's just double check with the other direction. So let's stimulate medial rectus and then TL lateral. Deep breath in, all the way out, and then don't let me push, and then checks out. So we're going to release the lateral rectus, and then we're going to activate medial rectus. Okay, Sky. So I'm going to use a Q-tip. I'm going to put that on the lateral rectus area here. You okay with that? Okay. So what you're going to slowly do, I can't actually block the right eye for me. Can you just block that? Great. And so I'm going to block the eye that we're not treating just so she can really focus on the left lateral rectus going on stretch. So I'm going to put some light pressure, Q-tip here. She's going to gently start to look over to the right. Nice and slow. Can I actually have you follow my finger? And now slowly, we're going to go this way. Very good. She may not give this up willingly. Very good. For her correction, we're going to patch the left eye when she's trying to strengthen the right medial rectus. If her left medial rectus were the one that was sore, we could have also started to pair those things together as well, but it wasn't sore, so probably not wholly dysfunctional tone. But that looks like it's about your limit. Okay, you doing okay? Okay, good. So now we're going to stimulate the medial rectus. What I like to do is do a cross stim. So this muscle runs in an anterior to posterior direction on the inner part of her canthus. What I'm going to do is cross stim, so it moves this way, right? I'm going to go across to be able to stimulate the fibers, but I'm also going to have her adduct the eye and block the left eye. Can you block the left eye for me? So the muscle's going this way, I'm going across. So here we go. Are you ready? Okay. So I want you to look into adduction. So far, let me know what you can talk about. Okay? Okay, good. So now I'm going to just retest by having her stim and TL one of them. And if it's still dysfunctional, then we'll attack something else. She's eye watering. Are you okay?
Well, you just said shit.
Deep breath in, all the way out, and then don't let me push. And so she stays strong here. So she's clearly no longer dysfunctional. So now we'll pull her up into her lateral subsystem. So let's stand you up. Let's put you here. Take your time. Okay, so we'll put you here for a second. You'll be super close to the camera, but that's okay. That's all right. Okay. And deep breath in, all the way out, and then don't push. Good. As in dysfunction, can you look to the left 5 times? 1, 2, 3, 4, 5. Back to neutral, deep breath in, all the way out, and don't let me push, and she can't be down-regulated. So her big homework is going to be to release the lateral rectus, to stimulate medial rectus, and I would have her do a lateral subsystem activity with the left eye patched. So what you're going to do is go into half kneeling for me, and left knee down, right leg forward. So we're going to get these hip AV and adductors, as well as this QL, trying to function for you, okay? But I'm going to need you to patch your left eye, okay? So you can cover it with your right hand, okay?
You don't want me to put duct tape up?
A patch is fine. I've given away all my patches in my office. I'm going to neutralize your neck. Good. And so what I want you to do is bring this foot a little closer, okay?
Closer like this
Yes,
way.
exactly. And I want you to take your right eye, and I want you to adduct it. We're going to try to activate this medial rectus, and we're going to try to quiet that left lateral rectus. You okay so far?
Mm-hmm.
So you can find a point over here where it's pretty much still in the lateral plane. You good to go?
Mm-hmm.
Focus on that. And I want you to gently start to lift your right foot. You can put as much pressure as you want on that left hand to help you. Shrug that shoulder. There you go. So just so you guys can see at home. She's activating her QL on the right and her hip ab and adductors on the left side. So she's basically strengthening that subsystem, but she's in left or right eye adduction, which is medial rectus. And she's blocking her left lateral rectus, so it's not going to compensate for her. Okay, good, relax. So I'll make sure I didn't blow her out. So let's stand up. Take a deep breath in, all the way out, don't let me push. Good. Take a deep breath in, all the way out, don't let me push. She's good to go. So now, can we go back and do your initial exam? So let's kneel in front of the camera. How's she looking, Michelle? She good? Okay, good. So here we go. Oh, a little higher, sorry. There, above the camera now. All right, so neck long, chin tucked. We're gonna try to reproduce the test the same. And she was missing her ability to do lateral movement, head stays straight ahead. And much better, Sky. Let's see if this one's still dysfunctional. If this is the primary, then the other one should dissipate. I still see a little dysfunction in that right eye's inferior oblique. Right, Sky? Yeah, so let's clean that up too. Sky, we're not gonna need anybody else. We're just gonna need you.
Well, I do what I can.
You do what you can for us, right? So we cleaned up one, but we didn't clean up the other. So I'm super interested in her superior rectus on the left and her inferior oblique on the right. So anterior sling for you and posterior sling, is there one that bothers you more than the other?
I think it would be my left posterior.
Left lat to right glute.
Okay.
You didn't complain of bilateral kind of QLE, which may be brachial lumbar fascia. Okay. Can you shift your ribs to the left for me? Just your ribs?
To my left.
Do you feel that on the left or the right?
I feel it on the right.
Okay, good. Do you shift your ribs to the right? Do you feel that on the left? Okay, good. So she's got pretty good functional thoracic lumbar fascia shift. When you shift your ribs to the right, you should feel it on the left. When you shift your ribs to the left, you should feel it on the right. She's good to go. Good. So it could very well be eye movement throwing off the subsystem. Okay.
Feeling it.
I know, girl. So anterior or posterior sling, I'm sorry, on this side. So hands gonna be on the posterior shoulder of the sling that we're testing and the anterior hip. Right? So posterior sling, lat, left, right glute. Yes? So I'm going to first just test in the clear because it was strong in the clear before, right? Take a deep breath in, all the way out, don't let me push. It's very strong in the clear. It's not her primary pattern, but we can still clean this up for her. Can you look over to the left and then up? This is going to help us really key into the left superior rectus and the right inferior oblique. Take a deep breath in, all the way out, and don't let me push. And that definitely does not give us a lock. So it's not going to be her big pattern. It actually makes her worse. Can you look over to the right and up? Take a deep breath in, all the way out. Don't need push. Good. Look over to the left again. I didn't make. Oh, it was strong in the clear. I'm so goofy. It was strong in the clear.
I'm
of
like,
course.
what the hell?
I know. What the hell am I doing? Yeah.
You just double checking some
I just
shit.
need lunch. So it's what I do on my lunch hour. I'm sorry, guys. She was strong in the clear. I was like, well, that didn't work because it's dysfunctional. So as she looks over to the left and then up, if she's strong in the clear, it'll go weak if it's dysfunctional. Take a deep breath in, oops, all the way out, and then don't let me push, and it does. Oh, dooley. So it's clearly dysfunctional. If strong in the clear, she does the movement and it makes her weak. Okay, so anything in particular, you said like lattish?
Like this lat right here has felt dead for years.
Okay.
So I can barely get my ass.
On the right side?
Yeah.
Okay, so let's test your left lat just as a global pattern. Okay, let's see what it is in the clear. Because it was strong in the clear as far as the subsystem, it does go weak on the movement. Deep breath in, all the way out, don't be full. But if we do your lat separately, it's weak in the clear, okay? And then on this side, glute max. Deep breath in, all the way out, don't be push. Oh, you are kidding. Let's see if we can get them to neural lock, okay? So let's look left and up. Deep breath in, all the way out, don't be push. Oh, Sky, your eyes are screwing up your posterior side. Deep breath in, all the way out, don't be push. Okay, so when she looks up and to the left, it does make her neural lock on these weak in the clear structures of the posterior sling. It's so interesting that when you're standing, the sling tests strong in the clear, and it goes weak when we therapy localize eye movement up and to the left. But when you're on the table, they're weak in the clear. So fascinating. Sky has a lot of trouble being able to congruently use her ability to do superior rectus function of elevation in an abducted position on the left, and use the inferior oblique on the right side. I need a new Q-tip. Now you're keeping me busy.
You're welcome.
So can I see if either of these are tense? So I think that these two muscles might tend towards a little bit more.
When I was palpating earlier,
Shoot. So I'm just going to palpate superior rectus. Sorry. Superior rectus is very tender on the left. Now on the right eye, we're going to look at your inferior oblique. So we're going to start at the maxilla, so right here. And we're going to trace our way up to the sclera. Are you the most sore at the sclera?
I think I'm just sort of like right here.
Yeah. So Sky is pointing to right here on the maxilla. So don't forget that spot. It's not always at the sclera. Sometimes it's coming from the maxilla for inferior oblique. Okay, Miss Sky, we think that your eyes are in a dysfunctional relationship to each other. The best odds are that the superior oblique on this side is throwing off the inferior rectus, superior rectus on this side is throwing off the inferior oblique on this side. But we want to make sure, right? So again, we know this is a pretty good indicator. Let's see if it still is. Okay, and don't let me push. Good. And then spindle cell compression to make sure it can be inhibited. And it can. So Sky, can you TL your superior rectus on the left? That moved the eye to the left and up. Deep breath in, all the way out. Don't let me push. It's not in a dysfunctional relationship with anterior delt. She's going to stim and TL it to bring cerebellar awareness to it. And then breathe in, breathe out. Don't let me push. And it is dysfunctional. Okay. So Sky, can you then go to the inferior oblique? Okay. She's going to go to the maxillary part. Good. She's going to TL it first to make sure it's not a dysfunctional relationship. Exhale, don't let me push. Now stim and TL to make sure that it's dysfunctional. Deep breath in, all the way out, and don't let me push. And it did. Ooh, my. Just kind of folded like origami. So now you're going to stim them both. So inferior oblique on the right, superior rectus on the left, stim, and then TL just one. Your dysfunction should cancel out. Deep breath in, all the way out, don't let me push, and it doesn't pair. We got lucky. Yay! Now you're going to stim the superior rectus and then TL inferior oblique. Deep breath in, all the way out, don't let me push. Man, you are so logical. There's nothing confusing about Sky. So the inferior oblique inferior oblique stimulation just to make sure, and then TL superior rectus. What you TL is what you test. Deep breath in, all the way out, and then don't let me push, and she neurobox. Okay. So, Sky, let's release your superior rectus. So for the superior rectus, rather than just have her depress the eye, I'm going to start her in elevation and depression. Can you patch the right eye for me with the right hand? I'm going to have her work in the thing that she's missing, not just elevation, but I'm going to pull her into abduction. So eye goes up and out. Yep. And now I want you to look down and in. Very good. Okay, and look up and out. Good. Now, look down and in. Good. And how you doing? You okay? Mm-hmm. Up and out. Down and in. Yeah. Easy peasy. Okay, let's go over to the other side. You okay? Mm-hmm. Let's patch your left eye. Good. Inferior oblique, we're going to start at the maxilla and kind of pull up towards the sclera. And now for this one, can you very carefully, I'm going to cross stem, and I want you to look up and over to the left to activate it. She's looking up and over to the left as we cross stem. This muscle is obliquely oriented, so I'm doing the X pattern opposite. And I'll do this until her eyes water, or she tells me it's just too intense, or until I feel the tension on the muscle start to decrease. She just did. Fantastic. She's a quick fix on this one because it's not her primary pattern, but it's still helpful to help the patient fully. Okay, Sky, let's recheck. The stem 1 and TL1, whichever one you want. And deep breath in, all the way out, and then don't let me push, and she's good to go. So no longer has dysfunction. Let's stand you up, Sky. And for an anterior oblique sling issue, or posterior sling issue, I would give you an elbow prop. So basically what you'll do is go flat on your back. Go flat on your back. Mm-hmm. And what you're gonna do is, there we go. So she's gonna bend her right knee. She's gonna plant her left elbow. Yeah, you can bend your elbow, there you go. And what you're gonna do is you're gonna patch your Oh, actually, yeah. Can you patch your left eye for me? Yeah. In the office, you can actually just have a patch. That would be good. What she's going to do is not let her left eye really be used. Or if I can trust you to close it, you can do that too. It's up to you. Okay. So I just don't want you to open that left eye because I'm afraid that your superior rectus on the left is going to inhibit your inferior oblique. Okay. So what I want you to do is you press through this left elbow to activate your lat to be able to press through this glute on the right side. Is I want you to look up and to the left with your right eye. Okay. And you don't have to come all the way up, but I just want you to initiate hip extension on the right and humeral extension on the left. Can you try that for me? Very nice. And come back down. Oh, that was just beautiful. We'll do an aerial view. Good. So she's activating her faulty pattern, not letting her left eye's superior rectus supersede her inferior oblique. Fantastic. Hopefully this will help her with the diplopia she was having in the right eye strain. Good, thank you so much. Floaters in the eye, by the way, just as an aside, are a sign of deficiency, usually with circulatory deficiency. So that will usually be the inhibited eye, just FYI. It's not always the case, so no absolutes. Okay, Sky, can I retest your perturbation? You okay so far? How you doing? You feeling loopy?
Feeling good.
People might feel a little loopy, so you just let them know, okay? And so here, take a deep breath in, all the way out, and don't let me push. Oh, she's a boss. That was strong in the clear before. To really eye dysfunction, she's gonna look up and to the left, and that made her fail because it was dysfunctional. Take a deep breath in, all the way out. Don't be, I am scared of this girl right now. Everything is strong and cannot be inhibited on relational compensation. So hopefully this helped you to be able to apply some of your eye movement to lateral subsystem movement. And if the person has a lot of suboccipital pain, neck pain, and your releases aren't getting it done, a good place to go is eye movement. If a person has diplopia or floaters, definitely go to eye movement. If they're a contact wearer, go to eye movement. If they have eye strain, go to eye movement. But most importantly, when you're doing an activation for your said subsystem, don't let them use the compensator. So you may have to patch them. Just FYI. Okay, so Sky, thank you so much. You're a boss.
Thank you.
Thank you so
Appreciate
much.
it.
Can't wait to hear about it if it helps her with her stuff. If an eye movement is something you don't are not normally going to because you don't think it's a problem for them, if your regular corrections are not working, a good thing to go to is eye movement because remember, it's pons and midbrain innervated. It's pretty high hierarchy. So if someone has like a hidden eye movement they don't even know about, just run them through a cardinal signs of gaze. If you get frustrated with perturbation, you can't get them to lock, might be the time to start doing cardinal signs of gaze and see if their diplopia, their eye strain starts to come out. Maybe their eye is palsied and they don't even know they have an issue with one of these cranial nerves. So working this can be very, very effective. Make sure they don't use their compensator during the activity. So patching can be a really good idea or just closing. I like to patch them if I can because I don't trust them to, not keep that open.
Can I add one thing?
Yes, please.
So before this eye correction she just made, overhead like this was very restricted and pinchy in the shoulder, and the pinchy's gone, and I feel like I have full range of motion here instead of being.
Damn, I wish I would have asked her that before. I took a crappy history.
Right.
Okay.
Let me see what my squat looks like. Yeah, I'm more upright now.
Oh, that's great. A little bit more lat, a little bit more glute.
I'm not this.
Oh,
Yeah. Maybe I can do a pull-up now.
She's more centered in her feet because she has lateral subsystem for pelvic stability for her squat. And now she can actually use her lat and her glute to get her out of the hole from the squat. So nothing but good things in the future when you start to work with eye movement. Eye movement is 1/3 of your equilibrium system. So it throws off proprioception very quickly. And if you don't assess it, it may be something that your patient's missing that they could really benefit from. When Sky works out, she's going to have to do proper eye targeting too. So remember, we had her eye target during her corrective strategy. That's something she's probably going to want to do when she lifts. Then she'll come in and get checked on to make sure it's still her pattern.
I'm going to fly all the way to New York for my follow-up next week.
She'll Skype with me. Okay, so Kristen, I wanted to make sure that you don't have any questions before we end the study group. Open up the chat box. Sky, thank you so much. That's perfect. Such a good example. When I do the triangle. When do you do the triangle, Kristen? So the triangle is going to show you some of the deviations. So you do that way before you do your manual muscle testing to try to determine if it's 2 eyes or 1 eye. Do you want me to redo the triangle to see if it's still dysfunctional? It'll most likely still be a little bit dysfunctional, but choose left eye moves to the right, close right moves to the left on myself. I'm not sure the question. Close the left eye, it moves to the right. Close the right eye, it moves to the left. Yeah, you have the exact opposite pattern of Sky, Kristen. So when you close your left eye, it moves to, let me make sure I have that right. Yeah, when you close your left eye, it moves to the right. You have a little bit more trouble with adduction or abduction, and Sky had more trouble with adduction. So you're the exact opposite of Sky, but same issue, same subsystem, most likely to start with. But for you, it would be the opposite pattern of Sky. Okay, yes. She said, just checking. Okay, thank you so much, Kristen, for being live. Thank you so much, Sky, for volunteering for the study group. And hopefully you guys find this immensely helpful. I'll make sure to get you the write-up along with the recording in the next 24 hours. Thank you so much.